That begs the question because there are a lot of patients in the pediatric population who have been started on a PPI for indications usually related to reflux disease, who are thought to be beyond the age where they should have outgrown it. And then the question becomes, can you, how do you, should you stop PPIs? So to address this, I'm going to just quickly introduce that case once again in follow-up. So that patient has been now treated with a daily proton pump inhibitor for the past 12 months. You did an excellent job of explaining the potential safety data, and they were happy with the use of it for the indication of healing the erosive esophagitis. So the patient's been asymptomatic for quite some time now, and they say to you that the gastroenterologist was still wondering whether or not they would be needed for long-term use, given the fact that the patient presented with an erosive esophagitis and the long-term data is not really well established, and it would be a potential risk to go off the medication. But they're still, wondering about this, and they ask you, can they stop the treatment at time now, because a year seems like a good length of time. And again, I think this is a common scenario that we face. And again, the old mantra had been that patients who are in need of PPIs because of significant reflux disease beyond the 12 to 18 month range, when they should be outgrowing in infancy, well, those patients who can persist to have some reflux disease, they have a more unfavorable long-term prognosis. And that may still be the case. We don't have a lot of long-term data. However, there are some studies that are worth looking at. Before I get there, I also wanted to go back to that part of the case earlier where she developed the reflux esophagitis following a viral infection. And that is an interesting point because infections in particular are quite common in pediatrics, and there have been some data suggesting that you can have a gastroparesis following or another associated infection that can last for up to a year in some cases. And if you have delayed gastric emptying, you could imagine that could certainly put you at risk for reflux disease. So again, one possible explanation as to why some patients have a short-lived reflux or reflux-associated disease that actually would potentially go away over time. But let's look at some of that data. So first, let's start with the maybe more pessimistic view. And this is a review of 32 patients who were in the pediatric age range, as you can see, who were initially assessed and found to have evidence of erosive esophagitis. All 32 were eventually able to achieve healing of the erosive esophagitis. And then the authors took an approach where they began with cutting the dose of omeprazole, which was used in these patients to induce the healing. They cut that dose in half for what they call the maintenance phase. The doses range between 0.35 and 1.75 milligrams per kilogram. And again, that dose was determined to be half the dose required to heal in the 3-month healing phase for each patient. And then they would assess these patients periodically, and if they had a relapse of symptoms or have actual erosive esophagitis on endoscopy, they would have a reassessment of the dose, which was often increased or doubled back to another dose that they were previously on. However, if every period of assessment there was remission, they would further reduce the dose by half. So it's not quite clear if they actually had an endpoint in mind of trying to get the patients off the medication, which does cloud a bit of the picture of whether or not the outcome is as bleak as shown in this article. But basically what they saw was that 60% of patients at the 2-year mark, or 21 months after healing, 60% still required more than half of the dose required for healing, which is to suggest that most of them relapsed to some extent as you try to wean them off the medication, and weren't able to go at least in half, let alone it being cut further by half. So they concluded first that the remission of erosive esophagitis is maintained with omeprazole treatment for at least 21 months in most children aged 1 to 16, and the drug is well tolerated, which is fair. You can also see that I've circled the erosive esophagitis grade at entry, and it didn't necessarily seem to matter what grade of esophagitis they had going in. Numbers were too small to run statistical analysis, although you do see that in the 1 to 6-year-old group, the vast majority of them did have some relapse of symptoms or of actual erosive esophagitis. However, even in the other groups, you can see there's still a significant rate of relapse. But what they also show, which is probably a bit more unique about the study, is that of the 32 patients enrolled, 13 of them had either a repaired esophageal atresia, cerebral palsy, or another neurological impairment. And of those 13, 8 of them relapsed in some way. So they also concluded that in children with gastroesophageal reflux disease predisposing conditions, GERD is often chronic and relapsing and requires long-term management. So definitely a bit of a skewed group here. But the message was that even if you look actually and parse out the data in those groups that were not at high risk, there still was a significant risk of relapse. But that can be contrasted with this study, which is certainly more encouraging. They enrolled all patients between the ages of 1 to 16 who had evidence of reflux esophagitis, which was considered grade 2 or above on the Hetzel and Dent scale. And you can see here I put time 0 or T0. They had 48 patients enrolled, and for 3 months they treated them all with omeprazole 1.4 milligrams per kilogram per day. Then they rescoped them all, and only 2 of the 48 patients did not have complete healing of the esophagitis, which was considered to be either grade 0 or grade 1 or, on the Hetzel and Dent scale. And of those 46, only 15 had complete symptom resolution, 31 still had symptoms. And this is where the so-called trial part of the trial phase began. And so what they did next is they took those 46 patients and they divided them into 3 groups. One group received omeprazole at half the dose, similar to the previous study. One group received ranitidine for a dose of 10 milligrams per kilogram per day, and one group received no treatment. And they all got that for 6 months, whatever treatment they were assigned. And then following that period of 6 months, they had 3 months where they presumably had discontinuation of their medications. And then they were reassessed again endoscopically. And of those 46 patients, only one of them had a relapse of esophagitis. It was in the group that received no treatment, but still 13 out of 14 of that group did not have esophagitis, as did the other 32 patients that either received omeprazole at a half dose or ranitidine at the 10 milligram per kilogram per day dose as a so-called maintenance phase treatment, and then also had weaned off. By that point, there was a significant decrease in the number of symptomatic patients. Only 12 of all 46 patients were symptomatic, and all of them were thought to be so mild that they were comfortable with stopping a PPI. So at this point, all patients were off a PPI except for that one of the 46 who had the esophagitis recur. And of those 45 patients that were left over, 44 of them were very nice enough to complete follow-up with them periodically over the next 30 months. So now we have a total of 42 months follow-up from the initial esophagitis. And of those 44 patients, only 3 reported mild and brief symptoms during the 30 months of follow-up thereafter, and all of them off a PPI. 0 of them required any acid suppression during follow-up. So really encouraging here to suggest that if you actually achieved healing and then did some sort of follow-up assessment, unfortunately in this case it was endoscopically at about a year out, if you had healing, you were very unlikely to actually have a recurrence of symptoms at any point over the next just under 3 years. So I think that it should become clear that it is reasonable to take patients in infancy and young childhood who've had reflux disease. It's still reasonable to trial them off this medication at some point and periodically. And it shouldn't really matter whether or not they had endoscopic evidence of disease or not, because in the healthy pediatric age groups, there still was a very good prognosis in that recent study. However, what the first study should show is the caution of patients who are predisposed to reflux long-term. So that would include groups that had neurological impairment, repaired esophageal atresia, and I would also add that from the literature, the other high-risk groups would be those patients with cystic fibrosis, as well as patients with a strong family history of reflux disease or esophageal cancer or Barrett's esophagus. So if you are going to trial these patients off the PPI, how do you do it? Well, again, the literature is not exact in support of this indication, but there have been a number of studies showing the effects of potentially hypergastrinemia in patients who are on long-term PPIs and then suddenly go off the medication, suggesting that there could be and probably will be a rebound acid hypersecretion. And that is a concern because it's a consequence that actually may make it difficult to come off the medication and may make people misinterpret the rebound symptoms as being a sign of failure of withdrawal of therapy because the reflux has persisted, and that may not be the case. It may just be a transient effect that they can push through or try and counter with the use of a tapering schedule. So in this study, they took healthy adults who did not complain of any reflux-related symptoms on a regular basis, and they put them all on a PPI. They put them on for, as you can see there, up to the week 6 mark, and they stopped the therapy in some of the patients and kept it going in others. And you can see that in the first week following discontinuation, there's a significant increase in dyspeptic symptoms reported in patients who were completely healthy prior to starting that PPI. And then over time, you can see then the statistically significant differences between the two abate, and it can take up to, you can see there, it can take up to 3 to 4 weeks for the symptoms to be back at baseline. And so again, what this shows is the potential rebound effects and the need to try and compensate for this. Now, how do you do the wean? Well, again, there's not a lot of evidence on clinical trials, so we have to go with expert opinions, and most would suggest that the longer you've been on the medication, the longer the taper should be, but I think that may not be well proven either, because there have been some studies suggesting that the degree of hypergastrinemia is pretty much the same whether or not you're on a medication for 6 months, a year, 2 years, or longer. It would also suggest that these periodic trials of trying to come off the medication can be beneficial because it may allow some patients to get down to a lower dose compared to what they were previously on while still having. So in summary, in otherwise healthy pediatric patients, reflux disease may not be chronic or recurrent after treatment as previously thought, and this is the case regardless of initial endoscopic findings. And the question still remains of whether or not we need to use endoscopy to document healing, but that study that suggested good long-term outcomes did have that as a suggestion. And then the evidence supports a tapering or weaning schedule based on some of that evidence about gastric acid hypersecretion following discontinuation. If it fails, you could go back then to the lowest effective dose, which may be lower than when you started. And then last, the question comes up of if the failed trial of discontinuation occurs, when would you retrial? And again, that has not been well established. Clinically, practically, we tell adolescents in our clinic often to try every 6 months to a year to come off the medication or to wean the medication slowly and see how low they can go. But again, that's just sort of a strategy that has come out in the absence of evidence to suggest one way or the other what to do. So thank you very much for listening in, and I hope you found this helpful in practice.